The Truman Katz Center for Pediatric Bioethics at Children's Hospital in Seattle presents its second annual conference, Ethical Issues Related to Vaccination of Children. The Truman Katz Center is the nation's first center dedicated solely to the study of research and healthcare for children. During this 5-part television series, national experts discuss vaccine policy, parental rights, and global controversies surrounding childhood vaccinations. In this program, Dr. Joel Frader, pediatrician and professor of medical humanities and bioethics at Northwestern University's Feinberg School of Medicine, will present how physicians view the issue, physician response to the parent who refuses to vaccinate a child. But first, Dr. Edgar Marcuse, professor of pediatrics and adjunct professor of epidemiology at the University of Washington School of Medicine and the associate medical director at Children's Hospital and Regional Medical Center in Seattle, presents Origins of Immunization Hesitancy.
Thank you. Good morning. Almost all physicians in primary care practice report having experienced parental refusal for one or more vaccines. Which vaccines are most commonly refused varies a bit, but measles, mumps, rubella leads the list, followed by varicella. And today, interestingly, the new acellular DTaP is rarely refused, a contrast to where we were prior to the development of the acellular vaccine. Amazingly to me today, the discussion about when is it appropriate to fire a vaccine-refusing parent from your practice is actually a subject of discussion. I have not seen any studies of this. It is my impression that this issue is more prevalent on the East Coast than on the West Coast, but this actually is a subject of discussion in professional journals. Now we come back to, do parents understand immunization? And a survey that I participated in almost a decade ago actually has been substantiated by smaller studies since that time. The vast majority of the US public supports immunization and would not opt out of any vaccines. The vast majority believe in mandates, and they believe that unimmunized children should be excluded from schools during outbreaks. However, while the majority of parents understand the benefits, there is a substantial majority that does not, and that has important misconceptions about immunization. And some of those misconceptions are listed here. About 1/4 of all parents believe that the immunization system or the immune system is weakened by too many vaccines. They believe that children get more vaccines than is good for them, and that in fact they have doubts about whether vaccines are proven safe prior to their use. This, having a full 1/4 of the country that have these concerns, greatly undermines the consensus that we have relied on to achieve high immunization levels. Now, when you look at why parents refuse vaccines, some issues rise to the top. Clearly, issues about vaccine safety are paramount. This concept, curious where it came from, of overloading the immune system. A concept that their children really are not at risk for these diseases, and I will talk more about that. And then a host of other issues. When we look at mandates, which will be the subject of further discussion later today, most parents, in fact, support mandates. And the wording of the question on the survey is a little bit backwards here, but it said, I'm opposed to immunization requirements because only I know what is best for my child. Well, 3/4 of parents who answered that survey disagreed with that statement. And again, over 3/4 of parents felt that children could be excluded from school if they were unimmunized. Well, let's look at what has happened here in Washington State. Washington State is one of those states that allow parents to opt out. And basically, our school immunization law is a law against apathy. Parents must sign a statement when a child is registered for school, which says either, my child has been immunized according to these standards, or I do not wish my child to be immunized. And if we look at the exemption rates by county here in Washington State, in 1999, it looked like is shown on this slide. The red represents counties in the state where greater than 5% of children opted out. Now, for those of you who are not in the health, or at least in the communicable disease world full time, I'd like to put that 5% into perspective. If you have 5% susceptibles for measles, say, in an elementary school, and there is a case of measles, the disease can do all it can do, which is pick off all the susceptibles. So 5% is sufficient to give you a sustained outbreak of measles. This is where we are in 2004, an obvious increase in the proportion of counties in which we have a larger number of individuals opting out of one or more vaccines. What's unfortunate is we know precious little about the reasons for their opting out, whether that represents deeply held philosophical beliefs or what some of us term convenience exemptions, which is they sign an exemption because they want to get their kid into school at that time, and maybe the immunization record isn't available. Well, if you look at the school entry requirements, they have increased dramatically over the last 4 decades. One of the ways we have achieved high coverage in this country, in contrast to some other countries, is through use of mandates. And in general, mandates have been used to boost cover or to increase coverage from levels around 70% up to levels in the 90%. And the classic example Dr. Kachi referred to, which was the measles outbreaks that occurred in the early 1990s, when we had rates in the 70 and 80% that essentially have been brought under control, and endemic transmission of measles in the United States ended by higher immunization rates. Now, compared to parents who vaccinate their children, those who refuse immunization tend to be older, better educated, and they're similar with regard to income and race. This really differs from the demographic characteristics of the under-immunized, where access to care is a central issue. Now I'd like to talk a bit about why this has come about, what I see as the origins of immunization hesitancy. First, there's no question in my mind that a decline in vaccine-preventable diseases, namely the success of our immunization programs, has had an impact. In my high school days, polio was of concern to my parents and the parents of every child. Today, most of these diseases are things that you read about in textbooks. So no longer are these diseases readily perceived as a threat. And to put this into perspective, when there's an influenza vaccine shortage and the threat of flu, be it avian, be it pandemic, whatever occurs, all of a sudden there's rather a demand for that vaccine. So disease threat clearly has something to do with the demand for vaccine. There's increasing recognition, I think, of the limits of medicine, science, and technology, and I'm going to spend a good bit of time talking about that. There's obviously been a resurgence of complementary and alternative medicine, which I think follows from the previous point, and then there is a growth of consumerism. No question that in the background there is the issues of malpractice and product liability litigation. How much of the hesitancy issues are sustained or reinforced by the fuel from these fires, I think is very, very difficult to assess, but it's too simple to blame it all on the lawyers. However, I enjoy showing this slide regularly. Now, this slide appeared advertising this firm's ability to assist you if you wish to bring suit because you felt your child was damaged by a vaccine. And this particular ad appeared in USA Today several years ago. However, always before I give this talk, I make sure that I call that phone number and see if it is still active. And indeed it is, in English and in Spanish, although the array of choices on the phone have changed. And some have dropped off and some new ones have been added. If anyone at the break could tell me what welding rods is all about, I would love it. Perhaps that's of concern to our orthopedic surgeons. Now, in the modern world, the scientific process has also, I think, been distorted. When Jenner had his idea that cowpox a vaccine from cowpox might protect against smallpox, what did he do? Well, he wrote a paper, and the first thing he did was he went to the Royal Society, where he presented the paper to his peers, and there was discussion. Then the paper was published, again in a peer-reviewed journal. Today, what happens? A hypothesis may be floated, published in an alternative journal or somewhere else. And what do we do as journal editors? Well, all these journals are competing with each other, and the first thing they do is about a week prior to publication, they send out embargoed copies to the press. So 24 hours before your family physician has an opportunity to read the study, it will usually show up on the evening news and maybe in fact be a subject for a news magazine report. The hypothesis of the investigator is then repeated by trusted communicators, be it Barbara Walters or Tom Brokaw or Katie Couric or whoever it is at that moment, and gets validated by repetition. The actual peer review process, that does this make sense or not, takes place in the background after there's been broad public discussion. There are differing criteria for causality between the medical or scientific world, the legal world, and the court of public opinion. And perhaps the best example here is breast implants. The best evidence is that breast implants do not cause autoimmune disease. However, the company was found liable. And if you ask the public if they are associated with disease, there's no question. So risk communication is enormously difficult. Stories are powerful. Case reports have an enormous impact. Immunization is controversial today, and therefore most of those who write about immunization are not the science reporters, but in fact are freelance writers and folks in talk radio who thrive on controversy. So today there is access to the media. The quality of information on the internet is highly variable. And then we have the issue of journalistic ethics. And Lord knows I am not an expert on journalistic ethics, but a key concept in journalistic ethics is the concept of balance. And I'm very fond of this a couple of paragraphs I've excerpted from the Scientific American, which says that good journalism values balance above all else. We owe it to our readers to present everybody's ideas. Politicians or special interest groups say things that are untrue or misleading. Our duty as journalists is to quote them without comment or contradiction. To do otherwise would be elitist and therefore wrong. And I would just point to the date of that particular thing because this was the April Fool's issue. But your silence makes clear that this was plausible. So it is a problem. The media do, in fact, value controversy over scientific truth. And the concept of balance is very, very hard to cope with. So I've got a series of names and initials here. And those who do not live in the immunization world may not know the difference between David Salisbury and Andrew Wakefield. They both speak with very credible British accents. They're both very charming. I think they both get away with a lot because they are charming and speak with British accents. But they very definitely differ in their qualifications and expertise. For those who may not know, Dr. Wakefield is the one who brought us the concept of measles and autism and was subsequently basically dismissed from his university and his papers rescinded. Dr. Salisbury is the distinguished head of the British immunization system. So this is a problem. They're both talking heads. Who do I believe? And over again, parents don't know, and good communication will trump good science every time on television. Then we have the limits, again, of the scientific method and how that adds to the communication challenge. So there you are with a microphone tossed in your face, and they say, well, is there an association between thimerosal and autism, doctor? And it is your job to answer that question. Well, when you do scientific studies, what you do is you seek evidence to reject the null hypothesis. You don't, and so you try to find evidence of an association so that you can reject the hypothesis. But you can't prove the null hypothesis. So you can't prove there is no association. This then leads to the kind of convoluted scientific language spoken by the Institute of Medicine, which is ultimately not terribly satisfying to the public because it doesn't answer their question. And the degree to which this is a public question is evidenced in this slide, which shows popular magazines, both in this country and the US, that have focused on these issues. The British write rather well about this, and I think this statement captures it. Today, risks receive a much higher priority. This is not just in medicine, but in our society in general. And it's not a question of one group of people being rational and others irrational, but rather how in our society today there are multiple rationalities and multiple truths. And this slide, though, I think nicely sums up the way many of us feel. That something we do in our lives can cause something in somebody. So today, experts, in fact, have been delegitimized as a source of authority. There are many, many different views based on different theories of the world. And as Dr. Smith in the British Medical Journal said, doctors and governments might hanker after a world where their view is dominant, but that world is fast disappearing. Now, what one is taught in schools of public health is that this is how one should think about benefits and risks. That it has something to do with the magnitude of the risk, be it for a complication or for death, and the probability of its occurring. That's the so-called hazard. But that is not the way people think about risk. We think about the perceived benefit and the perceived acceptability or unacceptability. And there's a lot of fascinating work about how we all perceive risks. And the human mind distorts them in various ways. For example, none of you would go climb one of our lovely mountains and in a thunderstorm hold up your umbrella because you'd be very much afraid you would be hit by lightning. But you're very, very likely to drive just down to the local shopping center without putting on your seatbelt. That's irrational. But we perceive risk in odd ways. We tend to overestimate the likelihood of very, very rare risks. So our perception of risk is absolutely subjective. It's quantifiable, and it's actually modifiable. By giving people information, you can, in fact, to change their behavior. And the best example I'm personally familiar with that relates to that is by giving men with prostate malignancies information about alternative treatments. You can, in fact, change their choices. Now, what diseases are perceived by the public as a threat to personal health or public health? So let's go back to 1967. Now, which of those diseases were perceived as a threat to the public health back then? And I would argue that those were. That measles, in fact, was not, because measles was part of the common experience. But people really were worried still about diphtheria and whooping cough and tetanus, and there's no question about polio. Smallpox was on the way out then, and that's really not a subject for our discussion today. So where are we today? Here is the list of vaccines we have, and which of these diseases are perceived as a threat to the health of an infant by a parent today? I would argue only those. Haemophilus, hepatitis A, rotavirus. You know, parent groups, Haemophilus never has been a source of concern to parents. They don't know that we've gotten rid of it. And meningococcal disease is absolutely a concern of parents today, although it's a fairly rare disease. Interestingly, polio, I believe, remains a concern, although the risk of polio in the US is really pretty small. So risk has something to do about how, in the public world, has something to do with the concept of outrage and the perception of the severity of the risk. So in the context of hazard, anecdote is not data, but it absolutely is data in the context of outrage. Let me say that in another way. When you're having a scientific discussion, an individual case report, a segment on Oprah with a damaged child is not data. But when you look at the outrage of a public who believes that a child has been damaged by a vaccine, that becomes data. It absolutely influences the discussion, whether it is, quote, an unfounded concern or not. To try to emphasize to you how much of a thread in our community this is, I'm putting up this slide from The Simpsons. The Simpsons had an entire program devoted to the concept that influenza vaccine was being used to manipulate the minds of the community. Now, what do they use as the themes for programs on The Simpsons? They're using cultural themes. So I rest my case. So it's important that we take care not to treat fear and reservation as ignorant and try to destroy them with a blunt instrument of rational science. So what is my solution to this? Taking a leaf from David Letterman's book, but in respect for the hour, I'm only going to give you the top 4. So the fourth one for me is that we in this country need to regularly assess the public's knowledge, attitudes, and beliefs about vaccines and about vaccine-preventable diseases. And I think we have failed to do this in an aggressive and intelligent way. This is, in fact, at least David Salisbury tells us that this is done regularly in England twice a year, where they, in fact, do focus groups to understand what are the issues that parents are concerned about vaccines, what are the issues they're concerned about diseases, and then tailor their messages to affect public perceptions of risks and benefits. I think that's called social marketing. We need to articulate what I call both the personal and the public health perspective, and they are different. The personal perspective is what makes sense for me. The public health perspective is what makes sense for our community. I think we have not spent enough time talking about what makes sense for the community and why, and I think we have. I think that's a card we need to play much more effectively. We need to involve the public in an open discussion of values. Science alone is not sufficient to make decisions. I've had the privilege of serving on the ACIP. I just completed my term. You do not have enough scientific information to make these recommendations. The values of the people around the table absolutely must and should influence the decisions. If values didn't influence the decisions, you wouldn't need the bloody committee, because it would be a scientific process. And I'll give you an example. Safety versus innovation. Safety is not absolute. How safe does an HIV vaccine have to be proven before it is deployed? How long will you tolerate the morbidity and deaths waiting for an assurance of safety? That's a values decision. Individual freedom versus community protection we'll discuss a good bit. I think there also needs to be discussion about media responsibility and the impact on the public health. So a preoccupation with science is no protection against the criticisms of a well-educated public. We have to be able to engage in a discussion of values with the public. And being able to engage in such a discussion requires media-savvy spokespersons who also understand science. And we have to assist our healthcare providers who are under increasing production pressure, particularly in primary care, to be able to engage in that total of 10 minutes that they have with a one-year-old, parent of a one-year-old, where you're supposed to be dealing with car safety, skin care, immunizations, feeding, but you also need to be able to elicit and respond to their concerns. These are enormous challenges. Our school laws have worked in large part because parents still today rely on the judgment and advice of their healthcare clinicians, their providers. And when you ask the people where do they go when they have questions, the vast majority still go to physicians and nurses. So I think we have an opportunity. Thank you for your attention.
Our last speaker will be Dr. Joel Frader. Joel is a professor of pediatrics at Northwestern University. He is the chief of general academic pediatrics at the Children's Hospital at Northwestern. He was the chair of the Committee on Bioethics for 6 years, some long period of time, when I was also a member of the committee. Joel is also focuses on palliative care and hospice care, and has been involved in a wide range of issues related to the interaction between physicians and patients regarding ethical issues. So it's my pleasure to invite Joel up here to give the final presentation of the morning on addressing the issue of parental refusals.
Well, thank you very much. The title that we saw before is not exactly what I'm going to talk about. I am going to talk about physician response to parents refusing vaccines. I'm going to talk briefly about a study that was conducted and I participated in. The principal investigator in that study, Dr. Erin Flanagan-Kligas, is here with us today. And I'm just going to mention some highlights from that study. So this is a response to Dr. Marcuse. There is a study that has looked at this question of physician refusal. There actually are two, in the sense that the American Academy of Pediatrics does a periodic survey of its members and asked a related question a few years ago. But our study, which was conducted just a few years ago, involved a random sample of American Academy of Pediatrics members, 1,000 of them, or just slightly over. And what was important from that study of those who returned it and who were primary care providers, so we only counted responses from those who actually were in a position to be providing vaccination. So if you were a neonatologist practicing in a tertiary care center and didn't vaccinate children, but you responded to the random survey, that's too bad, but we didn't count those responses. What was important is that 54% of those who responded said that they had encountered refusal to vaccinate in the previous year. What was more important and what we were really most interested in was the issue of how they would respond. And nearly 40% of them said that they would dismiss families who refuse to consider all vaccines. 40%. That was pretty surprising to us. Nearly 30% of them said that they would dismiss families from their practices if the parents refused some of the vaccines that are now available. So a very substantial proportion of those responding to the survey and whose responses that we considered to be valid, so primary care physicians, not only had fairly frequently encountered families who said, wait a second, we're not that interested, but had thought seriously about sending those people away, saying, get care elsewhere. What was also important in the survey is that it didn't matter how old the pediatrician was, whether the pediatrician was male or female, how long the pediatrician had been in practice. None of those things were important in their responses. There was, to a certain extent, a difference between those who said they would refuse to continue to care for families with respect to older, better established vaccines, so those that involve DTP, measles, mumps, and rubella, the Haemophilus influenza type B, and the polio vaccines. Now, that means that there is some distinction being made by pediatricians about the value of particular vaccines, whether that's based upon age, that is age that the vaccine has been available, or some judgment that pediatricians are making about the value of particular vaccines against particular disorders. We're not sure, but they do make some distinction between the more well-established, more traditional vaccines and some of the newer vaccines. When asked why pediatricians would dismiss families from their practice, they pointed to a lack of shared values as the main reason to ask families to seek care elsewhere. And I think Doug addressed this in an important way. Prevention and vaccination is the core of current pediatric practice. It's what makes pediatrics, or what has made pediatrics as successful as it has been over the last 50 or 60 years or so. So it's impossible, I think, for pediatricians to think about themselves and their roles in the community and their roles with families without recognizing and considering to be very important this preventive measure that we now have available to us. The other thing that was important in how pediatricians responded with consideration to dismissing was that they said that they were concerned about the lack of trust that patients had in them as healthcare providers, and that was another reason that they would consider sending people away to seek care elsewhere. So we conducted a random survey. We posed questions about what had happened and what people would do in response to situations where parents responded that they didn't want to have vaccines. One can always ask in situations like this, a survey, whether the results of our study accurately reflect the reality out there. It's important to understand that there's no, in a survey like this, there's no way to judge the accuracy of the responses. This is a hypothetical situation. We weren't, after all, observing behavior. We were only collecting information. And we know from social science that there is some distinction between what people say they will do in response to surveys and what they actually do. On the other hand, we know from discussions that we had both before we initiated the survey and from various responses to the publication of this survey that there's a good correlation between anecdotal information about what's happening out there and what people are doing and the kinds of responses that we got. And in fact, our results are similar to the American Academy of Pediatrics periodic survey. We observed a somewhat higher percentage of willingness to dismiss families than in that survey, but it's roughly in the same ballpark. And I think what this reflects, as has been discussed here, is the intensity of the social debate going on now about the importance of this. Having said that, I just want to add the caution that I think is appropriate for any survey-based research, that we may or may not have either overestimated or underestimated what pediatricians are actually doing in their offices. So what's important here? Well, I completely agree with what Doug has already said, that depending on the timing, that is to say, what's going on in the community, is there an epidemic, is this a college community where many of the students for religious reasons or other reasons have not been immunized and are therefore susceptible to measles, and in fact there's a measles outbreak in that community, or depending on geographic considerations, that is to say, there are, as we saw in the lecture earlier about what's happening here in Washington, there are differences in immunization rates from one area to another. Nevertheless, having said both of those things, the actual risk to most individual children in the United States is pretty small. More importantly, I think, what's driving patients, or parents, as we've heard already in the discussion this morning, is a range of things from the economic considerations to an enormous amount of distortion in the media. There's an awful lot of very sophisticated misinformation out there. If you go to Google and type in vaccine information or anything that involves vaccine, you will be sent to very large numbers of websites that are extremely slick. They're very well put together. Unfortunately, most of the information in them is wrong, but there's very little that an unsophisticated, untrained person can do to tell whether that information that's in those websites is wrong. So there's an awful lot of information out there which misleads people and gives the wrong impression about the scientific and medical information. A recently published paper that I think is really important also suggests another very big issue here, which, though they don't name it so directly, really has to do with the economics of pediatric practice. And they correctly point out that many pediatricians either cannot or will not take the time to address the fears of parents. So I'm just going to read to you a few things from their paper, which is a qualitative study, that is telephone and direct interviews with families who are both acceptors and refusers of vaccines. This was a study out of Yale, because I think it illustrates very clearly the kinds of issues and the kinds of experiences that pediatricians are having. This is a quote from one mother. "I went through a dozen doctors who were just being like, well, I won't treat you if you're not going to vaccinate your child." So when parents called pediatricians and either spoke with the pediatricians themselves or their nurses or their office staff, what they got back was dismissal. "We won't take you seriously. We're not interested. You're harming your child or planning to harm your child, so forget it." Another quote. "Because we wanted to find a pediatrician, I called 4 different pediatric groups that were listed in my medical insurance book, and all 4 of them said that they would not see my child. I had nurses on the phone who would normally book appointments. My question was, do you have a pediatrician who would be willing to discuss with us to vaccinate or not to vaccinate? Note, this is discuss. The response was, she was like, how could you do that to your child? So again, dismissal, failure to take seriously the parent's concern. Several non-vaccinating mothers, this is quoting from the article, not a particular individual, distrusted traditional medical care because of negative previous experiences with the medical establishment in general, such as misdiagnoses or poor communication about a diagnosis. As a result of those kinds of experiences, many of the families referred to in this article sought care from homeopaths and naturopaths. And I have to tell you that it's not just non-MDs that we're talking about who are supporting alternatives to vaccination. There is a very large and geographically scattered family practice group in the Chicago area called Home First, where family practitioners, MDs and DOs, board certified in their field, support families who do not wish to vaccinate their children. So it's not just a question of sending them outside the medical care system. It may be sending them to other physicians, licensed as physicians by the state of Illinois in our case, who are willing to support this. A few other things from the article that I think are important. Many of the parents who responded said that the doctors did not have adequate knowledge about vaccines, and the doctors did not have time to talk about the vaccines with the families. Many of the mothers distrusted the motives of pediatricians and the medical establishment and explained that vaccination was exclusively for making money for pediatricians and the vaccine industry. In other words, it's not just a question about whether people feel that they're getting good advice based upon science or their perception of science or based upon what medicine does or doesn't have to offer. It's a belief that there is a direct conflict of interest based on economic considerations that some families have about what it means to go to the doctor and be told that you need to have your child vaccinated. They reject this because they think it's simply a money-making ploy for the doctors or for the vaccine manufacturers. So how should pediatricians respond in this way? Well, what I'd like to emphasize is the importance of the doctor-patient relationship. And for me, what that means is that this is, in fact, about a relationship. This is about forming a partnership and making decisions with families that are based upon shared information and a sense of equality in at least the value portion of the decision making, if not knowledge about science or medicine. So from my perspective, and by the way, I want to say with respect to these remarks, this is my perspective, and I don't mean to represent this as either Erin's views or Lisa Sharp's views, my co-authors on this paper. We may or may not agree about everything that I'm going to say about this, so it's my perspective. I think it's extremely important in service to the relationship that I think is the core of what we as pediatricians have to offer for people, is the avoidance of preaching and the avoidance of condescension. If you read the Bennett article, what you get from that is the understanding that people don't feel as if they're being treated with respect, don't feel that they're being treated as valued members of a community with some sort of sense of shared decision-making. So it's our responsibility as doctors to foster mutual respect and trust, not simply to demand that people trust in us because we have degrees, because we've gone to residency programs, because we read the scientific literature, but based, again, upon the interpersonal relationship. I think it's extremely important that we understand that there are, in many cases, cultural and value differences. And again, as Doug has said to us, and I agree completely, in the context of a very small risk, that is the case for most of these circumstances, I think we can, by and large, tolerate a great deal of difference based upon culture and value. And perhaps most importantly, though it may be a major issue, I acknowledge this with respect to the economics of one's practice, is for pediatricians to learn to take the time to answer questions, to discuss misunderstandings and misconceptions that families have. So that might mean that instead of scheduling patients every 8 minutes or every 10 minutes, at least in the situation where you have a family who isn't likely to go along or is expressing doubts or concerns about that, that you schedule 20 minutes, that you schedule 30 minutes, that you have families come back to have further discussions about it. Not simply say, oh, well, if you're not going to buy my perspective on this, please go away. Now, again, it seems to me that one of the consequences of the please go away response is that it runs the risk of sending patients away where they don't have access to needed care, especially in emergencies. One of the things I think everybody in this room would like is if their child had an emergency that needed the response of a doctor, they would prefer to have a doctor who knows them and who knows the child and who understands the family's perspective and who can respond with that in mind rather than having to show up in a situation where there is no established relationship. So the business of access to needed care, I think, is very important. And as I've already alluded to, I think it's incumbent upon us to avoid driving families, particularly understanding that we're not talking about adults making decisions for themselves, but children who need our care. We don't want to drive families, therefore children, to substandard care. And I would say that the home first practice in the Chicago area is substandard care, and we don't want to do that. We want those children to come to us for care that we could provide, even if the families aren't willing to accept vaccination, at least at first pass. And again, I think it's appropriate to intervene with respect to appeals to child protective agencies, that is, public authorities, only when there's an immediate threat to health or safety of the child, a substantial risk of harm, as Doug has said. So what should we be doing? We should be educating families about the health implications for not just their children, but the health implications for other children who are exposed to unvaccinated children. So I think it's perfectly legitimate. In fact, I think it's morally required that when a family says to us, we don't want to vaccinate this child, and that child is going to be in a child care situation, we need to inform those parents that one of the things they're doing is putting other children in that child care situation at risk, whether those are children who are immunocompromised or simply younger and not yet able to have completed a series of vaccinations, say for Haemophilus influenza. It's really important that we carry out our roles as educators, going back to the origins of the notion of what it means to be a doctor, and provide people with information about that. I also think it's important to be flexible, and we can do things like alter the vaccine schedule so that if one of the reasons that parents are concerned about our vaccination policies is they don't want a child to get 4 vaccinations at once, yes, the Academy and the Advisory Committee on Immunization Practices want us to deliver vaccines in a particular way and according to a particular schedule. Nevertheless, I think most of us would agree that vaccinating the child on some schedule is better than not vaccinating the child at all. One of the responses, in fact, the editorial in response to the article that Erin, Lisa, and I published was to say, well, one of the things we can do is to have families sign a piece of paper or a legal waiver saying, we won't hold you, doctor, pediatrician responsible if something terrible happens as a result of our child not being vaccinated. Seems to me that misses the point. This isn't about being sued or not being sued. This is about what's best for children. And to put it in a legal context this way simply raises the specter of an adversarial situation rather than fostering the kind of relationship that I think we want. So I would say that sort of response, presenting families with waivers, really is the wrong thing to do. And more than anything else, as I think the responses in the Benin article suggest, what we want to do is to avoid abusing our, in many cases, better social and economic situation and simply overpowering people, overwhelming people and saying, you need to do it this way because I know best. So I think it's important for pediatricians to address these issues in a careful, consistent, and yes, time-consuming way in the office, but I also think it's important for pediatricians to engage this debate in public discourse. I think pediatricians should be going to school meetings and discussing the importance of vaccinations. I think pediatricians should be talking on Channel 5 when the opportunity comes up. I think it's important that we carry out our mandate as educators, not just with the individual families that we're engaged with, but with the community as well. So we should take every opportunity to educate the community at large. And very importantly, it's important that we acknowledge conflicts of interest on the part of some individuals and organizations who are, in fact, dependent on manufacturers' largesse. It's not just the fact that some families are worried about financial conflicts of interest. There are real conflicts of interest, and unfortunately, I would have to say that some of them are represented by some of our major professional organizations' dependence on the kinds of donations and flow of economic support that go to those organizations from the manufacturers, whether they're drug manufacturers, vaccine manufacturers, or device manufacturers. I think that conflict of interest issue is a real one, and we shouldn't be running from it. So my perspective on this is dismissing families is drawing a line in the sand, which is simply not appropriate. It's a dysfunctional line in the sand. There are very few situations when we want to be saying, stop, I don't like what you're saying, go away. The fact that we can marshal scientific and medical support for vaccine safety and utility simply misses the point in many cases because it doesn't address the fears and beliefs of many families. And reliance on this business of the integrity of the profession, that is to say, we as pediatricians know, because it's scientifically based, that this is a good thing, ignores the fact that yes, there are differences among professionals about some of these issues, as illustrated by the home first practice. And when it comes right down to it, there really is no moral gold standard that we can appeal to that says our values are better than others' values. Yes, our science may be better, but our values aren't better. So the line in the sand, the dismissal approach, is not one that I think gets us very far. And in fact, I think there's evidence to say that these heavy-handed solutions that many people want to engage in invite backlash. That is to say, as we say, go away, that makes people's positions be more entrenched. When we do this, we undermine trust in the profession, and that doesn't advance the health and welfare of children as a group. Driving children away from our care to care by less qualified individuals puts our patients at risk. And I think the evidence that dismissing families does that is a very grave concern, and we shouldn't buy into that. Thank you very much.
You have been watching a session from the 2006 Pediatric Bioethics Conference, Ethical Issues Related to Vaccination of Children, presented by the Truman Katz Center for Pediatric Bioethics at Children's Hospital in Seattle. For more information about immunizations, please visit the websites listed here or go to seattlechildrens.org/bioethics. The Childhood Immunization Schedule, www.cdc.gov. The Immunization Action Coalition, www.immunize.org. The Influenza homepage, www.cdc.gov/flu.